The clinical management of tension-type headaches. What do we know about the prevalence of tension-type headaches? Okay, we know that the 1-year prevalence is between anywhere from 30 to 80%. It is probably the most common form of headaches in Singapore, and for that matter, anywhere in the world. Okay, tension-type headaches. For example, a population-based study in Denmark showed that 69% of men and 88% of women suffer from tension-type headaches. Another telephone-based survey in the US showed that about 38% of people have tension-type headaches. Okay, and in our own country, we have had a study showing that about 40% of Singaporeans or Singapore residents suffer from tension-type headaches. So it is not inconsequential, the number of people who have tension-type headaches, and certainly by far is the most common type of headaches that we see. How do we define tension-type headaches? Well, there are various types of tension-type headaches, and without going into too much details, the main ones are infrequent episodic tension-type headaches, frequent episodic tension-type headaches, chronic tension-type headaches, and probable tension-type headaches. Okay, these criteria were defined by the IHS, or the International Headache Society, which is a grouping of headache specialists, and they published this under the guidelines published in 2004. So there's this new thing since the 2004 revision has come out, infrequent or frequent episodic tension-type headaches. Why this new subdivision? Infrequent tension-type headache has very limited impact on the individual. Okay, most people with infrequent tension-type headaches defined as less than one headache a month, one tension-type headache a month. Most of them don't even come to see any of us, GPs, specialists, because what do? They self-medicate. They buy the Panadol, they take the Panadol, and most of these patients, they get better, and they never see a doctor. All right? Only when it becomes more frequent, or their OTC medications are not giving them good effect, do they come to the attention of a medical professional. Okay? And many of them who come have frequent tension-type headaches, defined as anywhere from 1 to 15 headaches a month. Okay? And these people having 1 to 15 headaches a month can suffer from quite significant disability. Right? And then sometimes it requires medications for prophylaxis. So at least 10 episodes of occurring less than 1 day per month, okay, with 2 of the following main characteristics: bilateral pain, pressing or tightening in quality, mild to moderate in intensity. On a 0 to 10 scale, no more than a 6. All right, not aggravated by routine physical activity, and they need to have both of the following: no nausea or vomiting. You can either have photophobia or phonophobia, but not both. Then infrequent episodic tension-type headache is subdivided again into headaches associated with pericranial tenderness, okay, where you have pericranial tenderness when they have the headaches, and episodic tension-type headaches not associated with pericranial tenderness. For frequent episodic tension-type headaches, there are at least 10 episodes occurring more than 1 day a month, but less than 15 days a month. Okay, and they have to have it for at least 3 months. And again, the same criteria, bilateral, not severe in pain, not aggravative activity, etc. For chronic tension-type headaches, these are headaches that are more likely to see doctors, specialists, because they have headaches occurring more than 15 days a month by definition, for more than 3 months. Again, the common theme that runs through all these tension-type headaches: the bilateral, pressing quality, mild to moderate intensity, non-aggravation by physical activity, no nausea. Mild nausea or photophobia or phonophobia, but not all of them, and certainly no vomiting. Okay. The problem we have with tension-type headache is that it's such a wide, it covers so many things, and so many people have it. It's not well defined. Okay. It's not so much about what it is, what type of headache it is. It is unilateral, is this, is that, rather than it's not, than what is not. It should not be pulsating, it should not be severe, there should not be nausea, okay? So the difference between tension-type headaches and migraines then, some of the features that are common with migraines, the triggers, with the migraine triggers for women, menses, stress triggers, skipping meals, having insufficient sleep or sleeping and waking at different times than you normally do. So any kind of triggers are more likely to have migrainous features, okay? And many tension type headache patients have headaches with a migraine biology. So we think that with tension type headache, the pathophysiology is in the muscle mechanisms, all right? Because with injection of saline and electrical stimulation, they can also cause cranial muscle pain. We also know that in tension type headache patients, the pericranial muscles are more tender than in healthy controls. And in chronic tension type headaches, EMG activity tends to be higher in these patients than controls, okay, but not related to how severe the headache is. And also, of note though, there is no increase in EMG activity during a headache compared to EMG activity in the absence of a headache for these group of patients. There may be central mechanisms involved, such as central sensitization, all right, where the brain is sensitized from repeated frequent attacks, supraspinal modulation of incoming stimuli, and also this whole thing about nitric oxide mechanisms. So the treatment for acute attacks, well, there's a couple of things that have grade A evidence, level 1, such as paracetamol, aspirin, ibuprofen, ketoprofen, okay? And then for grade B, a level of evidence, we have naproxen and diclofenac, okay? And these all are effective for the acute treatment of tension type headaches. And then a lot of people ask about COX-2s because those are your typical NSAIDs, and people sometimes are sensitive with gastric sensitivity, etc. But really, there is limited data on COX-2s at this moment in time, okay? So it cannot be recommended yet. However, caffeine, though, has been used as an analgesic adjunct. And in all these papers published here, there is some evidence that suggests that caffeine is effective as a treatment for tension type headaches. Okay? Now, prophylactic treatment should be considered when the headaches are frequent. Okay? And this is grade D evidence. Level 4, they should be started if they have very frequent headaches, and we, like everything else, we start at a low dose and to go slow. So start low, go slow, until the patient responds or until there's side effects and you cannot go up anymore. Amitriptyline, anywhere from 10 milligrams to 75 milligrams, has level 1 evidence for efficacy and should be one of the first things that it should be considered if you feel that your patient requires a prophylaxis for their tension type headaches. Other locally available medications with less evidence includes Remeron, Ludimol, and Anafranil, and these are grade B level evidence.